Hello, and welcome to a short review on the care of the dialysis patient. During our AKI CKD lectures, we discuss bits and pieces about dialysis patients, but this lecture is meant to solidify some of those concepts we touch upon. HD, PD, CRRT, and transplant fall under the umbrella of renal replacement therapy. It is important to note that sometimes non-treatment is also an option, especially for your patients facing end of life and others simply choose such options. The indication for hemodialysis, or HD, focuses on symptoms of uremia and severe electrolyte imbalances. Electrolyte imbalance, usually seen due to elevated potassium levels, can be life-threatening and require correction through dialysis. This can lead to symptomatic acidosis, which is when the body's acid-base balance is disrupted, leading to symptoms that dialysis can help manage. For patients that may have overdose or have toxic levels of drug, dialysis can be indicated for toxin removal. Hemodialysis is used in cases of drug overdose to remove toxins from the bloodstream. When a patient have a GFR less than 10 mL per minute, a very low GFR indicates severe kidney dysfunction, signaling the need for dialysis. In summary, hemodialysis is necessary when there are severe electrolyte disturbances, symptoms of uremia, acidosis, toxin accumulation, or a critically low GFR. This slide covers the goals of hemodialysis, which include removing excess fluid to help patients reach their dry weight, reducing symptoms of fluid overload. Remember that dry weight means measuring the patient's weight at the same time before breakfast using the same clothes. Blood pressure control is also a goal of hemodialysis by managing fluid levels and improving overall cardiovascular health. Another goal is to remove toxins and excess electrolytes, such as potassium, to prevent complications associated with electrolyte imbalances. You also want to improve acidosis by filtering out excess acids in the blood, thereby restoring a healthier pH balance. These objectives aim to alleviate uremic symptoms and improve the patient's overall well-being. In hemodialysis, solutes and water move across a semi-permeable membrane from the blood to the dialysate, or from dialysate to the blood, and they usually run counter current. The blood's going this way and the dialysate's going this way. Waste moves through the membrane, this membrane, and into the dialysate for it to be wasted later. This is regulated by concentration gradients, so diffusion, osmosis, and ultrafiltration are at play here. Creatinine, uric acid, and electrolytes move from the blood to the dialysate. This lowers their concentration in the blood. White blood cells, red blood cells, and platelets stay in the blood because they are too big to pass. If the dialysate is contaminated, it is possible for viruses and bacteria to pass in the blood. Glucose is added to dialysate to create an osmotic gradient across the membrane, and that is what pulls excess fluids off. Ultrafiltration is the process of removing excess water across the dialysis membrane due to an osmotic or pressure gradient. In peritoneal dialysis, or PD, the osmolality of the dialysate is increased by adding glucose, creating an osmotic gradient that facilitates water removal. In hemodialysis, water removal occurs through changes in pressure gradients. In HD, there is an increased pressure in the blood compartment, that's the positive pressure, and there is a decreased pressure in the dialysate compartment, that's the negative pressure, which helps draw water across the membrane. This process effectively removes excess fluid and toxins, managing the symptoms of uremia. This is what a hemodialysis system looks like. The system is primed with saline. A needle is inserted into the access to remove blood. The blood is propelled through a blood pump and into the dialyzer through, again, through a blood pump. Heparin is infused in the pre-dialyzer to prevent clotting. The dialysate is then pumped into the dialyzer, and remember that counter current flow is going this way while the blood is going this way. And this is where diffusion and ultrafiltration occurs. The old dialysate is then discarded into the stream, and then blood is returned to the patient through the second needle access, or what they usually call the return needle. The benefits of hemodialysis are that it efficiently removes excess fluids from the body, quickly eliminates waste products from the blood. It is highly effective in maintaining proper potassium levels, can help reduce high triglyceride levels in the blood, and you could also do it for a temporary access. It can be easily placed at the bedside for immediate treatment. For example, for your patients that have consumed toxic amounts of medications and are needing emergent dialysis, you could just quickly put a right IJ trialysis or a right IJ dialysis catheter to get dialysis initiated for that patient. Hemodialysis can also be adapted for use at home for suitable patients. It does require 8 to 12 weeks of training. They go to a dialysis center, get checked off on being able to access their catheter and de-access their fistula as well, being able to run the dialysis themselves, set up the machine, order their supplies, and monitor their labs, monitor their own vital signs. And this does require a second person as well for the patient in case of an emergency, that second person should also be certified to troubleshoot the machine. Hemodialysis typically results in less protein loss compared to peritoneal dialysis due to differences in the dialysis process and membrane characteristics. So the dialysis membrane in hemodialysis, the blood is filtered through an artificial semi-permeable membrane that is specifically designed to allow the passage of waste products and electrolytes while retaining larger molecules like proteins. This selectivity minimizes protein loss. The In peritoneal dialysis, the peritoneal membrane acts as the filter and the dialysate comes into direct contact with the peritoneal cavity. Because of the nature of the peritoneal membrane and the prolonged exposure of the dialysate, there is a continuous small loss of protein. Additionally, the use of glucose-containing dialysate can sometimes alter the peritoneal membrane, potentially increasing protein leakage over time. So the structural differences between the membranes and the nature of the dialysis process itself results in less protein loss during hemodialysis than peritoneal dialysis. Some challenges and considerations in hemodialysis are that patients may experience unstable blood pressure or other cardiovascular issues due to rapid fluid removal. Hemodialysis requires skilled healthcare professionals and specialized equipment to monitor and manage the procedure. Quick removal of fluids and waste products can affect electrolyte imbalance, requiring close monitoring. Blood thinners are used to prevent clotting in the dialysis machine, which comes with a risk of bleeding. Sometimes when patients are on Coumadin, they do not need to be heparinized. It just depends on what their PT, INR, and PTT are. Small amounts of blood can be lost during the dialysis process, especially if there are issues with the access site. Vascular access, such as a fistula or graft, is necessary, and its maintenance is crucial for effective treatment. The dialysis membrane must be compatible with the patient's blood to avoid reactions or complications. This is why it's crucial to keep the patient's access and lines visible at all times during the dialysis. If the access becomes dislodged, the patient can quickly lose a significant amount of blood. Remember that machine is pulling blood at a rate of about 250 to 300 mLs per minute. Additionally, patients must be on therapeutic anticoagulation to prevent clots from forming in the line, which could potentially lead to a thrombus. Monitoring the patient's hemodynamic status is equally important, as pulling fluids too quickly or in excessive amounts can deplete their vascular volume. In such cases, volume expanders like crystalloids, normal saline, or colloids, albumin, may need to be administered to stabilize the patient. Access is one of the most difficult issues in HD. This is what prevented chronic renal failure patients from being able to benefit from dialysis until the development of a Teflon shunt that could be accessed repeatedly. Can still be an issue for patients with compromised vasculature, though. This is why nephrologists do not like PICC lines because they want to preserve the veins for future dialysis access, especially for your patients with elevated creatinine already. Patients with chronic renal failure will likely need hemodialysis in the future, which requires the creation of a vascular access site, such as an arteriovenous AV, again, arteriovenous AV fistula or graft. These access sites depend on healthy veins, typically in the arms. Placing a PICC line can cause scarring, damage, or thrombosis in these veins, particularly or potentially compromising the sites needed for future dialysis access. Dialysis requires a rapid blood flow, so it needs a large vessel. A double lumen catheter, one for blood removal, one for return, and a large bore, it has to be a large bore. It could be tunneled or non-tunneled. Non-tunneled is used for short-term dialysis, 1 to 3 weeks, but a tunneled catheter can be used for longer access. Tunneling prevents infection. It has a Dacron it has a Dacron cuff, which prevents tracking of infection along insertion site. It can be a bridge to a more permanent access, such as a fistula or a graft. The advantages of a central venous catheter access are that it can be used right away for patients needing urgent dialysis. Again, those tunneled lines may provide additional venous access for infusions, increasing their utility. Temporary lines offer emergency access, making them suitable for short-term or emergency dialysis. This is typically for your ER or ICU patient that need immediate dialysis and are too unstable to go to IR or interventional radiology and get a tunneled line. The disadvantages of having a central venous catheter access are that it poses an increased infection risk. Catheters can lead to a higher risk of infection compared to other access types. It also is generally intended for short-term use and can be prone to clotting or other complications. And then chronic use may lead to vessel damage, so potentially complicating future access options. An AV fistula has better overall patency and least complications like thrombosis or infections. It's more difficult to create though, especially with peripheral vascular disease or with a patient that is an intravenous drug abuser, and it takes 1 to 3 months to mature. Most nephrologists want to wait at least 3 months. The Steele syndrome happens when the fistula diverts too much arterial blood away from the hand or distal extremity, leading to inadequate blood flow in that area. The symptoms of Steele syndrome are coldness or pallor, pain or cramping, numbness or tingling, and weakness. Fistulas are preferred. They have a 3-year patency rate of 70%. Usually less than one-third of patients have fistulas though. Surgeons' preference, expertise, elderly patients, diabetics with poor vasculature is some of the reasons why only one-third of patients have fistulas. The choice of hemodialysis access depends on a patient's arterial system. So veins available for access creation, patient's life expectancy, and planned duration of hemodialysis. The patient's cardiovascular status is also important. Some access can significantly alter hemodynamics and cardiac output. So, for example, my father-in-law had a terminal diagnosis, and he was given a prognosis of life not beyond 6 months, but he needed dialysis urgently and continuously, actually, because he ended up with end-stage renal disease. So we couldn't get an AV fistula because it didn't make sense to wait 3 months, get him through that procedure, and then wait for 3 months for it to mature. So he just had a subclavian hemodialysis catheter. A native anteriovenous AV fistula is created by connecting a vein to an arterial wall using the patient's own vessels. It's used for patients expected to be on long-term dialysis. This is the best vascular access for dialysis, performing better over time than synthetic AV grafts. AV grafts are made of artificial material, so it's more prone to infection and more prone to clotting off. A synthetic AV graft is created by placing a prosthetic graft or bridge between a vein and an artery. Synthetic grafts are used in patients expected to be on long-term dialysis who lack suitable vessels for native AV fistula creation, or patients in whom native AV fistula have failed prior. The polytetrafluoroethylene graft provides a large surface for cannulation and can be used within 2 to 6 weeks of construction. Puncturing a graft before local tissue incorporation can cause large subcutaneous hematomas and poor graft healing. This is why you want that to mature completely. These practices are essential to maintain the integrity of the dialysis access and prevent complications. You want to avoid taking blood samples or measuring blood pressure on the arm with the dialysis access to prevent damage. Avoid wearing jewelry like watches on the access arm to prevent pressure or obstruction to the fistula or graft. Place a sign to indicate the location of the dialysis access, serving as a reminder for staff to avoid using the arm for other procedures. Check the access for proper blood flow every shift. Listen for a whooshing sound, that's bruit, using a stethoscope indicating blood flow. Feel for a vibration, that's thrill, over the access site, which signals proper function. Regularly inspect the access site for signs of infection such as redness, swelling, warmth, or discharge. Infection may require total removal of graft. Hemodialysis aftercare complications include a sudden drop in blood pressure, often due to rapid fluid removal during dialysis. Can cause symptoms such as lightheadedness or fainting, or sometimes your patient will say, I see dots in front of my eyes. Usually you want to give your patient some time to recover in the bed or the chair before activity. Resulting from fluid shifts and blood pressure changes, dizziness is a common after effect of hemodialysis. Patients may experience bleeding from the needle insertion site, especially if clotting time is prolonged due to anticoagulants used during the procedure. Muscle cramps can occur due to shifts in fluid and electrolyte balances during dialysis. Patients often feel tired or exhausted post-dialysis because of fluid and waste removal, which can be taxing on the body. Monitoring for these complications post-dialysis is essential to ensure the patient's well-being. You also want to watch for dialysis disequilibrium syndrome, or DDS, is a rare but serious complication that can occur during or after hemodialysis, especially in patients new to the treatment or those with very high levels of urea. It is primarily caused by rapid changes in the composition of the extracellular fluid during dialysis. It happens uh, because during hemodialysis, urea and sodium are removed more rapidly from the blood than from the cerebrospinal fluid. This creates a high osmotic gradient between the blood and the brain. As a result, fluid shifts into the brain to balance the osmotic gradient, leading to cerebral edema or swelling of the brain. Signs and symptoms to watch out for are nausea, vomiting, headache, confusion, and restlessness, seizures. In severe cases, patients can experience decreased levels of consciousness or even coma. To treat and manage DDS, you want to slow the hemodialysis process. Reducing the rate of dialysis helps to prevent those rapid shifts in fluid and electrolyte balance. Uh, might need to administer hypertonic saline to balance osmotic pressures and reduce cerebral edema, or give an osmotic diuretic like mannitol. Mannitol can be used to reduce cerebral edema by drawing fluids out of the brain. To prevent this, for patients at high risk, such as those with very high urea levels, initiating dialysis at a slower rate and more frequent but shorter sessions can help prevent disequilibrium syndrome. During hemodialysis, especially at higher blood flow rates, patients can experience periods of reduced blood supply to the heart. This occurs because of the body is removing large volumes of blood quickly, reducing the amount of blood available for the heart's own circulation. The heart may not always recover immediately even after blood flow is restored post-dialysis. This ongoing lack of adequate blood flow can lead to cumulative and potentially permanent damage to the myocardium, known as myocardial stunning. Over time, repeated episodes of myocardial stunning can weaken the heart muscle, contributing to chronic heart dysfunction and increasing the risk of heart failure in dialysis patients. To minimize the risk of dialysis-induced myocardial stunning, fluid removal during dialysis should be carefully managed. It is recommended that fluid removal should not exceed 13 mL per kg per hour to prevent excessive stress on the heart. This phenomenon highlights the need for careful cardiovascular monitoring and individualized hemodialysis plans for patients to reduce the risk of long-term cardiac complications. Peritoneal dialysis uses the peritoneal membrane, which lines the inside of the abdomen, as a natural filter to cleanse the blood and remove excess fluids. Here's how it works. A sterile solution known as dialysate is introduced into the abdominal cavity, also known as peritoneal cavity, through a catheter. This dialysate stays in the abdomen for a period known as the dwell time, which typically lasts 3 to 5 hours. During this time, waste products and excess fluids pass from the blood vessels in the peritoneal membrane into the dialysate. After the dwell time, the used dialysate, now containing waste and excess fluid, is drained out of the abdomen. A fresh dialysate is then added, and this cycle fill, dwell, drain is known as an exchange. The peritoneal membrane acts as a natural filter, allowing waste products and fluids to move into the dialysate. The peritoneal dialysis catheter has two Dacron grafts, one inside and one outside. It anchors and prevents movement of bacteria along the tract. It can be used immediately after placement, but usually doctors want to wait 2 weeks. PD is done continuously, either manually, CAPD, continuous ambulatory peritoneal dialysis, or through a machine, automated peritoneal dialysis. It can be done while patient is sleeping. The cycler fills, dwells, and drains automatically. You can see it right here, and that's what is usually used in the hospitals as well. Dialysis solution is placed into the peritoneal space, known as the fill, and that's about 1.5 to 2 liters of solution. It's left there to dwell and can be short or long depending on the type of dialysis. Fluids are removed, also known as ultrafiltration, by osmotic force. The glucose in the dialysis draws fluids out, and then waste products are removed by diffusion. Peritoneal dialysis offers several advantages, especially for certain patient groups like children or those with cardiac complications. Some key benefits include patients have more autonomy as they can manage their dialysis at home. It allows for a more adaptable routine, making travel easier. Compared to hemodialysis, patients on peritoneal dialysis often have more flexibility in their diet. And it eliminates the need for needle insertion as well, which can be beneficial for those with needle anxiety. It's Peritoneal dialysis preserves residual renal function. Particularly, this is important in pediatric patients because it helps them maintain overall health. It's also safer for patients with cardiac conditions as it causes fewer rapid fluid shifts. These advantages make peritoneal dialysis a preferred option for certain individuals, allowing for a better quality of life while managing their condition. The disadvantages of peritoneal dialysis include that the patients must take on more responsibility for their treatment, which can be challenging. It also takes more time compared to other forms of dialysis requiring daily or nightly sessions. Patients have a permanent external catheter which can affect their body image. There is an ongoing risk of infection at the catheter site, known as peritonitis. Unlike hemodialysis, peritoneal dialysis does not have off days, making it a daily commitment. Peritoneal dialysis generally removes fluids more slowly than hemodialysis, which can be a disadvantage for patients who need rapid fluid removal. Due to the use of glucose in the dialysis solution, patients may experience weight gain as well. Patients may require multiple abdominal surgeries due to catheter issues or infections. It may not be suitable for frail individuals if they do not have a caregiver to assist them. The glucose content in the dialysis solution can make it challenging for diabetic patients to maintain glucose control. Nursing care of the peritoneal dialysis patient include following the physician's prescribed orders for dialysis exchanges, including the frequency and duration of each exchange, to ensure the patient receives the appropriate dialysis therapy. You want to regularly assess the patient for signs of infection, such as peritonitis or infection at the catheter exit site. Look for symptoms like redness, swelling, tenderness, discharge at the exit site, or cloudy peritoneal fluid, which may indicate peritonitis. Perform proper exit site care, including routine cleaning and dressing changes to prevent infection. Use sterile technique when handling the catheter and during dialysis changes to minimize infection risk. Keep a close watch on the patient's overall response to peritoneal dialysis, including vital signs, fluid balance, electrolyte levels, and any symptoms of discomfort or distress. Document all findings and interventions accurately. Be vigilant for symptoms of peritonitis such as abdominal pain, fever, nausea, vomiting, or cloudy effluent. Prompt identification and treatment of peritonitis are crucial as it can lead to sepsis if left untreated. The manifestations of peritonitis are that the patient might be experiencing the following symptoms. There is a cloudy effluent in the drain, indicating the presence of white blood cells in the peritoneal fluid. This is often the first sign of infection. Your patient might be experiencing abdominal pain or cramping due to the irritation and inflammation of the peritoneal lining, and they might have a fever as the body responds to the infection. Also, nausea and vomiting just from the overall systemic response to infection, and your patient could often be feeling generally unwell or fatigued. There also could be fibrin strands, maybe that is visible in the drain fluid, indicating inflammation. This symptom should prompt immediate medical evaluation to prevent progression to sepsis. The treatment for peritonitis involves administering intraperitoneal antibiotics, which is the standard care over a 7 to 21-day period. Additionally, it includes managing symptoms. Monitoring for potential complications like sepsis is crucial. During the treatment, an alternative method of dialysis should be used until the infection has resolved. CRRT, or continuous renal replacement therapy, is an alternative dialysis method used for patients who are hemodynamically unstable and cannot tolerate traditional hemodialysis. This process occurs over 24 hours, closely mimicking natural kidney function. Because CRRT is continuous, it removes fluids and waste more gradually than standard hemodialysis, minimizing hemodynamic instability and reducing the risk of complications related to rapid fluid shifts. I prefer this mode of dialysis because we can manage it directly at the ICU bedside as a primary nurse. CRRT is a slower process, allowing us to control hemodynamic factors more effectively. Patients generally respond well to this treatment. We perform serial labs and replace electrolytes to monitor its effectiveness while also managing hemodynamic instability caused by dialysis. For critically ill patients, especially those who are septic or have poor cardiac output, CRRT helps to remove excess fluid, alleviate the strain on the heart, improve kidney function, and can potentially reduce their dependence on vasopressors. This CRT usually lasts from days to a week or even longer, and then the main goal is to get the patient stabilized and fluid overload resolved or decreased, so that way the patient can eventually, if their hemodynamic status improves, then they can tolerate the regular hemodialysis, which is usually just for 2 to 3 hours. Thank you for your attention today. I hope this presentation has given you a deeper appreciation for the complex and vital work dialysis nurses perform. While it can be challenging, with proper training and education, you too can become a skilled dialysis nurse. Renal disease is a significant cause of death and disability in our society. Therefore, we need not only proficient dialysis nurses, but also ambulatory care and inpatient nurses who are well versed in caring for renal patients, including focusing on disease prevention.